Hello, good morning. What a lovely morning to see all these bright and beautiful faces here. Thank you so much for taking the time to come and attend this. I wanted to go ahead and introduce myself. I'm Pooja Singhal. I'm a gastroenterologist in the community and one of the founders of POWHER, and we'll talk about that here in a second.
So I'm Dr. Jessica Enix. I'm a board-certified general surgeon focusing on women's health.
And I'm Dr. Anu Bajaj, and I'm a board-certified plastic surgeon.
And I'm Stephanie Taylor, and I'm also a board-certified general surgeon, and I do primarily breast.
Thank you. So we are here. We founded this organization called POWHER, and it stands for Physicians of Oklahoma for Women's Health Revolution. And this came about in 2023 as something that we all kind of were talking over the dinner and realized that there's so much need for these kind of events, the public forum where we can advocate for good medical health information, advocate for women's health, have a safe space where we can discuss issues, the common trends, and that's where this POWHER was born. And I want my co-founders to also talk about this. So I'm going to keep pausing.
So over the years, excuse me. Over the years, this event has grown and developed and changed. And we just hope to continue to be able to offer it as a free event, accessible to everyone, where you can not only attend, but also ask questions. It's a great event that we also give you the information that we think we see a lot, and so you can take that with you and empower your own visits with your physicians.
So this is our mission statement, and our mission is to provide a comprehensive and compassionate access to care, education, and to support unique women's healthcare needs. Through advocacy and innovation, we strive to empower all individuals to achieve optimal health at all stages of life. And what we felt like when we put this together is that there's really a lack of good health information that's easily accessible, because navigating our healthcare system today is difficult, even if you kind of know the ins and outs. And so hopefully we'll be able to provide you with information, as well as in the future we hope to have more events and more educational offerings for all of you.
So our core values are innovation and evidence-based practices to improve quality. So we think that that's super important. This is not just what you read off of TikTok or Facebook or wherever. We want evidence-based medicine. Compassionate care. We want to prioritize both your physical well-being and your emotional well-being. Collaboration. So it's all of us. This is multiple levels of people, from surgeons to GI doctors to psychologists. So we hope that we can all just give you the knowledge that you need to empower you for advocacy for yourself. And so in your little bags, one of the things that we did was 5 things that a woman should ask her doctor. And so when you're going through, that'll be in there and something you can just take. So, and obviously our focus is on education and outreach. And so I want to kind of give you just a little bit of housekeeping activities. Or information. There are restrooms in the very back, so you can do that anytime. And there are food and drinks. There's lemonade, water, coffee, and a whole little food bar over there. And the way that we generally set this up is we'll have 3 or 4 speakers, each quick, and then at the end of the speakers, we'll take questions, probably 3 questions or so, but you can find us anytime. And at the end of each big session, we'll also do a name drawing or a raffle. So if you didn't, you should scan the QR code so that you're registered. And we have some fun door prizes that will be good, including some skins care and a beach bag and some artwork. And what was the last one? What was the other one?
It's a DAXI and microneedling treatment.
Oh, microneedling treatment. So lots of fun stuff. There's a picture booth in the back. And the alarms are going off for the air conditioner right now, and so they're on their way to try to help us make the air conditioner better, so we're very sorry about that. So at the end of the day, the very last thing is going to be the final door prize. But right before we do that, we're going to do tours of the building so you can see what the mammogram machine looks like, what a breast MRI machine looks like. We've got bone density. So there's several of us here. But if you need to leave early, we would still love for you to see the facility if you would like to. So just let somebody know, and one of us will sneak out and take you around.
Thank you. I would definitely encourage you guys to take this opportunity to definitely tour this facility, because mammograms can be a bit vulnerable and scary, and this facility is very, very, does a great job to make it a very safe space. The last thing I just wanted to mention is this is truly an event run by all of us and our sponsors. We have a few sponsors, so a big shout out and thank you to our lovely sponsors. So if you'd like to see these events more, please do leave that feedback. So thank you.
Okay. And then we will start with our first session.
All right, everyone. So session 1 is really, we have this every single year. This one will never change. This is our screening session to talk mostly about cancer prevention and cancer surveillance to make sure that we don't miss the really, really important things that we can potentially prevent. So I'll ask all of our speakers to go ahead and come up, and I'll introduce them. Go ahead. Yes. All right. So Dr. Singhal, you met her. She's our gastroenterologist. She'll be speaking with you about colon cancer screening. Dr. Wiley is our gynecologist. She owns In Bloom Gynecology and OB here on the south side. Dr. Lingham is here with dermatology. Everyone always loves her skin cancer discussion and prevention and screening. And she is with Spectrum Dermatology. And then, of course, Dr. Taylor, our breast surgeon. In the other sessions, we'll introduce, we have Dr. Joffrey this year. She's our newest speaker. We're really excited to have her. And then Dr. Langhans is here about all things mental and sexual health. All right, starting with Dr. Lingham.
Good morning. Thank you so much for inviting me back again this year to speak about skin cancer. I'm going to start with, thank you, yes. Why should you care about skin cancer? As most of you know, skin is your largest organ, and the most common type of cancer is skin cancer across the board. 6 million people are diagnosed every year with basal cell carcinoma or squamous cell carcinoma, and 250,000 are diagnosed with melanoma. And 10,000 people die every year from skin cancer, and all of those deaths are preventable. So we're going to talk about another statistic. 1 out of 5 Americans, by the time they're 70 years old, will develop a skin cancer. So what causes skin cancer? More than 90% of skin cancer is caused by ultraviolet radiation. The vast majority of that comes from the sun. Most of us are not spending our days at the beach, but we are in our cars. And the photo in the middle shows a picture of a truck driver. You can see how much exposure to ultraviolet rays we have just sitting inside our vehicle, next to a window in our home, in our office, and just all of the short trips we take outdoors. There's a cumulative effect that increases the risk over your lifetime. And tanning bed use. Tanning beds are carcinogens. They are like cigarettes, and they substantially increase the risk for skin cancer, and in particular for melanoma, and disproportionately, that will affect younger people. Does skin cancer only occur on sun-exposed skin? So in my office, I do a lot of skin checks, and I ask my patients to take their shoes off, and they'll say, well, why are you checking my feet? Why are you checking between my toes? Why are you checking my buttock area? That never gets any sun. But keep in mind, skin cancer can develop anywhere that you have skin, and it can develop anywhere that you have pigment-producing cells. So we'll talk more about those examples here. This is a picture showing melanoma inside the mouth, on the palate. The middle photo is anorectal melanoma that was mistakenly diagnosed as hemorrhoids. And the third photo is a vulvar melanoma, which just looks like a nonspecific red patch of skin on the labia. There's also ocular melanoma, which is the most common cancer affecting the eye. And you can see that it can be very subtle, and it's often diagnosed at a later stage. Melanomas on your palms, your soles, in your nail unit is called acral melanoma. It's the most common type of skin cancer in skin of color. And famously, Bob Marley died when he was only 36 years old from a melanoma under his toenail that was thought to be blood from a soccer-related injury. This is a case of acral melanoma that I diagnosed in my clinic in a 60-year-old female who had told me there was a splinter injury on the bottom of her foot, developed a bruise. The bruise never resolved. And this photo here shows how it looked through dermoscopy, which is the magnified view that we have through the dermatoscope. And it was an irregular spot. It was biopsied, and it was an invasive melanoma. So what are the risk factors? On the left are risk factors that you cannot modify. Getting older, having fair skin, red hair, skin that burns easily, tends to freckle, taking medications that suppress your immune system, having had a basal cell or a squamous cell will increase your risk for a melanoma, having a lot of moles or very large moles further increases that risk, and having a family history in a parent or a second-degree relative of melanoma can increase the risk. So it's important to know what type of skin cancer your relative had. A lot of times someone will say they had a melanoma and it was burned off their skin, which doesn't make any sense. So it's important to really know your family history. Tanning beds are a significant risk factor, sunbathing, having 5 or more sunburns, or 1 or 2 blistering sunburns, even if it happened at a younger age, even if the tanning bed exposure was decades ago, it increases your risk as you're getting older for all the skin cancers. Someone who has a lot of precancers that often feel like sandpaper, they're rough to touch, they're gritty, they're frozen off with liquid nitrogen. Even though these do not tend to become actual skin cancers, it's like a canary in a coal mine. It does increase the risk for all the skin cancers that we see when you have a lot of precancers. Special groups, organ transplant recipients, are at 100 times greater risk for developing squamous cell carcinoma. Outdoor workers, I had to include a picture of a skid steer for my son. That's one of his favorite construction vehicles. And pilots, cabin crew, high altitudes, much higher intensity of UV. Their risk for a melanoma is double that of the regular population, and firefighters. Do I have to worry about skin cancer if I have brown skin or black skin? Yes, you do. It is less common to have skin cancer if you are non-white. However, the risk of having a more advanced skin cancer is greater because the awareness, the surveillance is not as robust. And acral melanoma, like I said before, is the most common cancer in skin of color. What are you looking for? Every person should do a monthly self-skin check, and that doesn't mean you scrutinize every mole or spend hours looking at your skin. Just a 5 to 10 minute check of your skin. Learning what you have, being aware of something new, something unusual, something that's changing, or an ugly duckling. An ugly duckling is a spot that doesn't resemble anything else on your skin. And oftentimes, this is the sign that I rely on when I decide what to biopsy. And a lot of times we do find melanomas and atypical moles using those characteristics. So the most common skin cancer is basal cell carcinoma. It is often on sun-exposed skin, so scalp, ears, face, neck. In women, a lot of times their upper chest and the back of the arms. It can look like a pimple, a sore, a shiny bump with a little crater in the middle. It can even look like a scar. It can sometimes look like a patch of red skin, like eczema, that's just not going away with steroids or moisturizers. And basal cells can also be brown or black. They're not always pink or red. Although the mortality from a basal cell carcinoma is very low, if it's untreated, it can be locally invasive and destructive. So it does need to be treated. Squamous cell carcinomas are the second most common type of skin cancer. They're usually scaly, warty, sometimes rapidly growing, and also on chronically sun-exposed skin. Which is the skin cancer I have to worry about the most? Melanoma. We're all familiar with this picture of the ABCDE signs of a melanoma, but I think this misrepresents how a lot of melanomas actually look. So this is a picture of a melanoma on the leg. The legs are the most common surfaces for female patients to have melanoma because melanomas preferentially show up on skin that is intermittently exposed to the sun, not chronically exposed. This is a melanoma on the back of the ear, and the third photo is a melanoma that's within a cluster of barnacles called seborrheic keratoses. The rest of those brown spots are benign, but the melanoma was sort of hiding within that cluster. This is a melanoma on the cheek called a lentigo maligna. These look like freckles, but on dermoscopy, they have some characteristic features that are helpful. A melanoma on the back of the arm on those last two photos. This is a very good example of an ugly duckling. This melanoma is perfectly symmetric. It has no color variation. It has a smooth border, and it's smaller than a pencil head eraser, but it's an ugly duckling, and this was a melanoma. This photo is a 43-year-old female that came in for skin tags, just a routine skin check, and she had no idea this was on her back, and it was a 0.7 millimeter invasive melanoma. I had to call her during the snowstorm and tell her about this. Melanomas are not always brown or black. They can be pink, they can be amelanotic. These are really hard to catch early, but they're important to recognize. Why do melanomas have a higher probability of mortality? Because the melanoma often starts at the top surface of the skin, but it can start to invade into the deeper layers. And once a melanoma has reached a lymph node, the prognosis at 5 years, mortality rates are, survival drops to 74%. If it goes to an organ, like the brain, the liver, or the lungs, that survival rate drops further to 34%. But remember, a melanoma that's caught early, 5 years survival is 99%. So early detection saves lives. This is a patient I had in Fort Worth. He was a landscaper. You can see how photo damaged his arm is in contrast to his torso. He presented with a rapidly growing nodular melanoma on his arm. It was treated with surgery. This third photo shows the surgical site with the graft. He had refused to have a lymph node biopsy done, and a few months later he came back and there was a nodule proximal to that original melanoma. So the rate of recurrence and morbidity is much greater. How does skin cancer get treated? Surgery. You've heard of Mohs probably, it's commonly done. It's a technique that is skin sparing, and the cure rate with Mohs is 99%. Melanomas are treated usually with a wide excision. Skin cancers that are superficial can be scraped or treated with the chemotherapy cream. And then melanomas that are more advanced now have a wide range of therapeutic options. How do you lower your risk? A lot of times when I'm doing a skin check, my patients will say, I did so much sunbathing, tanning bed, it's too late, the damage has already been done. But it is not too late. Wearing sunscreen daily, if you plan to brush your teeth that day, you should wear sunscreen that day. So regardless of your plans, you must wear sunscreen. 30 SPF is minimum, 50 is ideal for days that you're gonna be more outdoors. Hats, long sleeve shirts, sun protective clothing, paying attention to the UV index, which is part of your weather app. If it's greater than 2, you need to wear sunscreen. So pay attention to that in addition to just checking the temperature. getting an annual skin check if it's clinically indicated based on your risk factors, and checking yourself monthly, and eating a healthy diet, not smoking. What are the top 5 skin cancer myths? Sunscreens cause skin cancer. That is absolutely false. Sunscreens prevent skin cancer. If you're worried about chemical sunscreens, just avoid them. Use titanium and zinc-based mineral sunscreens. Vitamin D is how you want to, the reason you're getting exposure is to produce vitamin D because your levels are low. That is a really inefficient way to build up your vitamin D stores. Supplements and diet are the optimal route. A tan will protect you from a burn. Tanned skin is sun-damaged skin, so you want to avoid a tan, a baseline tan from the sun or from a tanning bed. Only older people get skin cancer. There's a lot of young women in their 20s and 30s who develop invasive melanomas, often a consequence of tanning bed use. And the fact that skin cancer is not serious. Skin cancer is preventable. It's the only cancer we're going to talk about today that you can actually visually see on your own skin. It is preventable, and it can be deadly, so it should be taken seriously. 5 questions to ask your dermatologist. Ask them what your risk factors are based on their exam and your personal and family history. Ask them how often you should get your skin checked. Not everybody needs an annual skin check. Your skin check might be every 2 to 3 years based on your risk factors, the density of moles you have. Which sunscreen do you recommend? Dermatologists know a lot about different sunscreens, and I'll tell you my 2 recommendations. Are there any moles that you want me to pay attention to? There might be a mole that they want you to follow at home, so ask them if there's something they're worried about. And then, do I need to discuss anything with my family? If you have a lot of moles, you should have your family members also be checked. If you've been diagnosed with a melanoma, you should share that with all of your relatives. I've had a patient for many years whose mom died from a melanoma when she was in her 40s. Her skin checks have always been quick, easy. There was never anything concerning. And her last skin check, she had a severely atypical mole. These are my 2 current favorite sunscreens. CeraVe has a newer sunscreen called Invisible Mineral Sunscreen. It has titanium and zinc only. It's a milky consistency. It absorbs well, no white cast. And I use it on my toddler, and he doesn't cry and run away as much. And Elta MD is a great line of sunscreens. I really like their UV Skin Recovery, which is transparent zinc oxide finish. It's really good. And then lastly, I had to just include this. This photo on the left was taken by Dr. Dana Bach, who was my anesthesiologist. And I was hoping she would be here because I just wanted to acknowledge her. I was on the precipice of motherhood, about to have my planned C-section, absolutely terrified. And her skill, her warmth, her compassion, her competence has stayed with me for my whole life. I can't believe I'm crying. And I just think that everything we do when we interact with our patients, our actions can really echo throughout their whole life. So I did not expect that. I'm so sorry. And this is my son wearing his sunscreen at daycare. And please feel free to email me if you have any questions. The Skin Cancer Foundation is a great resource. Thank you.
Thank you so much. And we will have a time allowed after this first session where everyone can ask questions. And again, you can always come up to us in between and ask specific questions. Next up, we have Dr. Singal with Oklahoma Gastro Health and Wellness, and she will be talking colon cancer screening.
Thank you. After that lovely talk about babies and motherhood, let's talk about colon and poop. Let's get right into it. I'll be talking about colon cancer screening. This is personally something very dear and near to my heart because this is why I wanted to become a gastroenterologist, because when I learned there is a cancer that can actually be prevented by doing simple tests, that was mind-blowing concept to me in med school. There are lots and lots of cancer that we have the ability to detect, but very few cancers we can actually prevent. So having said that, let's get started. The goals here today are to address some of the very common questions I get from patients. How common is colorectal cancer? What is colorectal cancer and why should I care? What causes it? Can it really be prevented? What can you do to prevent this? Okay? And I wanted to put pictures of this United in Blue installation. This is an installation of blue flags at the Capitol Hill in DC, and this is to bring attention to the rising crisis that colorectal cancer is no longer the cancer associated with elderly. We all used to think, oh, when you turn 50, that's when we need our colonoscopy. Well, more than 27,000 flags were displayed this year alone, and they are to highlight the 27,000 flags are the people expected between ages 20 to 49 years old, less than 50, that are expected to be diagnosed by 2030 with colon cancer. So, name a US president. Can you guys, I mean, you saw the answer, but can you guys name a US president who has brought attention to this topic? Ronald Reagan, actually. He was our 40th US president. He was diagnosed with colorectal cancer. In his second term, doctors found a polyp, a cancerous polyp, and he had to, thank you. He had to get 2 feet of his intestine removed. Fortunately, he was able to be cured of it by early detection and early diagnosis, and then he later on passed away at age of 93 with Alzheimer's. So how common is colorectal cancer? Well, it is the 3rd most common cancer in both men and women in the United States. It's now the 2nd leading cause of cancer-related deaths in US. A cancer that can be prevented is now the 2nd leading cause of cancer-related deaths. More than 50% of cancers colorectal cancer can be prevented by screening with a colonoscopy. So what is your lifetime risk? It's 1 in 24, actually. So just look around this room, okay? Let that sink in. 1 in 24. So it's 1 in 23 in men and 1 in 25 in women. So average risk is 1 in 24. Approximately 150,000 new cases of colorectal cancer are going to be diagnosed this year alone. So what is colon cancer, right? So before we get to that, as my 6-year-old would say, Mommy, last week he just had this epiphany and he was like, how is poop really made? So we went down this hole of, let's talk about colon. So colon is this large intestine organ right here, and it is about 5 feet in length. And rectum is this last 6 inches part of the colon. So when we talk about colon cancer, it's used interchangeably with colorectal cancer. So the cancer can affect any part of the colon. And what this organ does for us is it reabsorbs the water and makes the waste solid so we can poop it out. So cancer really, just like you just heard the dermatology talk right now, cancer is abnormal cells inside the organ. So we have normal cell lining in the colon. When we have small growths of abnormal cells, that can become a polyp and then turn into colon cancer. So let's see if you guys are paying attention. Colon cancer is the 2nd leading cancer killer in America. Is that true or false? Yes, it's true. Yay. I wanted to give tribute. As I go through this presentation, I did want to highlight some very, very popular people in our culture who have unfortunately died of this cancer, really to highlight both men, women, and races, that this really doesn't spare one sect. We are all equally affected by this. So Chadwick Boseman, very unfortunate case, very talented actor, lead in Black Panther, He died at age 43 after being diagnosed with stage 3 cancer in 2016. Jackie Robinson, a very big baseball player, died in 42, at age 42. A note about the rising incident of colon cancer in younger patients. I started my talk saying that, and I think it's very, very important that you take that message back with you. Anybody that you know who's about to turn 45, now, 45 is the new age for colon cancer screening. It's not 50, okay? Family, nieces, nephews, daughters, son, anybody, they should be discussing with their doctor about colon cancer screening. In fact, I'm trying to get my husband to get screened, and we're working on it. He has 1 year. James Van Der Beek, as you guys may very well be aware, Dawson's Creek, he unfortunately passed away earlier this year at age 48 after being diagnosed. And later, you know, this came out and he brought a lot of public attention to this disease, but this was also very unfortunate. He had no risk factors for this as well. Colon polyps, I talked to you about the polyps. This is what a polyp looks like. This is the normal, nice, pink, healthy lining of the colon, and the polyps can be hyperplastic and adenomatous. Hyperplastic are completely benign, and adenomatous are precancerous. They're showing me the wrap-up sign, so I'm gonna go ahead and try to get through this very quickly. So what are the screening options? There are 3 different types of screening options. The stool-based test, that's what you hear in the public all the time, like Cologuard, Cologuard Plus, FIT testing. FIT tests the blood. Cologuard tests the DNA, multi-targeted DNA. And now there's a newest test, which is SHIELD, which is a blood test, and that tests cell-free DNA. But the best test still remains to be the gold standard, which is colonoscopy. And the reason for that is you're having somebody trained directly visualizing your colon, and in that one step, removing the polyps or removing anything else that needs to be removed that's concerning. So, because we are getting out of time, I did want to highlight one more thing. There's a misconception that if I don't have symptoms, I don't need to be screened. That is not true. If I want you to take away one thing from my talk, it is, if you're age 45, you need to talk to your doctor about colon cancer screening, period. If you're having symptoms, that means there's already something going on, okay? It doesn't need to be cancer, it could be something else, but waiting for symptoms to show up may be too late. Colon cancer in its early stage does not display any symptoms. So these are the symptoms. If you're having this, definitely talk to your doctor. Blood in stool, change in shape of the stool, abdominal pain that's not going away, prolonged constipation, anemia, unintentional weight loss. This is another example of a big celebrity, Ruth Bader Ginsburg, second woman to ever serve on Supreme Court, also had colon cancer. Do both men and women get cancer? Yes. Okay. 45 is the new 50. What can you do? Get screened. 150 minutes of physical activity per week has been shown to reduce colon cancer, or your risk for colon cancer rather. Limit alcohol and red meat intake. Eating fruits and vegetables actually decreases your risk. And tobacco, no smoking tobacco is associated with it. So lastly, be the reason someone gets screened. Okay, I urge you to talk about it, get screened, and be the reason to get somebody else get screened. There is a photo booth back there. Please hashtag it. I'll tell you, I was on social media recently, and one of the patients messaged me. She had canceled her colonoscopy, saw my post, went back, scheduled it, and she actually had stage 1 colon cancer, no symptoms. So thank you so much for your attention, and feel free to email me or reach out.
All right, thank you, Dr. Singhal. Colon cancer is actually the reason I got into medicine. I was not on track to go to medical school, and my own grandmother died of metastatic colon cancer. So I do not do the screening, but I actually do the surgery. So I want everyone to know, just by doing your colonoscopy, you decrease your risk of colon cancer. Dr. Singhal takes that polyp out and stops that cancer growing process. So next up, we have Dr. Wiley, our gynecologist with In Bloom, here on the south side.
Hello. So I just want to say, speaking of influential physicians, Dr. Singhal just did my colonoscopy, TMI, and it was a delightful experience. So I promise. So cervical cancer screening. So we do this through a pap smear. I think most people are familiar with that, and hopefully everybody, maybe not everybody, there's a few men in here, but has had a pap smear. What that really means is that it's the part of a pelvic exam, part of a wellness annual GYN exam, where we're screening for cells on the cervix to look for cervical cancer. It often gets misconstrued as, pap smear is the well woman exam, but it's just a piece of that. So that it also generally includes a breast exam, just a general wellness exam, and then also a pelvic exam. It's quick. It can be life-saving. I think that I would love to see us get away from being terrified of pelvic exams and pap smears, and especially for young people. There's some young girls in here, and I would love for us to quit making pap smears seem scary and terrifying, because they shouldn't be. They're not fun, of course, but neither is going to the dentist. And if we can get more people in, less people scared and apprehensive about a pap smear, I think it can make a big difference. So what are kind of the guidelines? This is always a little bit mind-blowing for some people, that we don't start pap smears until 21. A lot of people think, well, you have to have a pap smear as soon as you're sexually active or when you turn 18, and that's really old school medicine. 21 is the pretty standard hard rule screening age for starting pap smears. From the ages of 21 to 29, then it's pap smears with reflexive HPV testing, and we'll get into HPV. But that is every 3 years, meaning it's just simply screening for cells, and then if there are abnormal cells noted, then we reflex test for HPV, looking for high-risk strains. From the ages of 30 to 65, this is actually new, very new as of this year. We're actually going away from pap smear plus primary HPV screening to primary HPV screening only, within reflex cytology, looking for abnormal cells. After the age of 65, you don't need pap smears anymore necessarily, as long as there's no history of abnormal or severe cervical dysplasia. Now, again, that does not mean that you don't need routine gynecologic care. Doesn't mean you don't need routine gynecologic care. It just means you don't need the screening of the cells on the cervix. Okay, so where does HPV come into play here? So HPV is the human papillomavirus. It is the main and almost only cause of cervical cancer. It's very, very common. Most sexually active individuals have been exposed to HPV at some point in their life. That doesn't always mean that you will show the outward signs as far as cervical cancer, or that will ever show up, but most people have been exposed at some point in their life. There are many strains, and there are some high-risk strains, which is what can lead to the cervical cancer. So here's what's exciting, though, is that we have a vaccine that has been around for 20 years now. It still sometimes, I think, is treated as a new, controversial vaccine, but it's actually been around for 20 years and is one of the most well-studied vaccines of all the vaccines that we have. Who should consider it? So recommended before the age of sexual activity, 9 to 12, but is approved up to 45 years old. So people with multiple or new sexual partners, those that were not vaccinated as a teen, and even those who have any recent or past history of abnormal pap smears, we know that vaccinating even a little later in life, may help decrease the severity of future cervical dysplasia. So it is the only cancer-preventing vaccine that we have, and I think that's huge. Okay, so just like colon cancer, often cervical cancer has no symptoms at all. By the time that you note signs of cervical cancer, it's often too late, meaning that there's a distinct mass on the cervix versus just dysplasia, abnormal cells. Screening catches things before they become dangerous. And so I tell patients all the time, even if you have an abnormal pap smear, as long as we're staying on top of it, you should never progress to a cervical cancer. So what's new? I kind of touched on this. So HPV testing itself is becoming the new primary screening test versus the pap smear. So whereas we used to screen cells, then reflex to HPV, it's kind of flipping because we know that HPV is the cause, and detecting that early can change outcomes. So this is also exciting. There is new self-collection tests that are becoming available, meaning you can go into your doctor's office instead of doing a speculum exam, brush for the pap smear. You can collect cells in your vagina and your cervix on your own. And so that can be really good it's kind of along the lines of Cologuard at home, and then if that's abnormal, then further testing is warranted. But this could be really good for some individuals who maybe are apprehensive about pap smear testing and that kind of thing. Okay, so cervical cancer, easier to prevent than treat. And then make an appointment with your gynecologist.
All right, thank you, Dr. Wiley. Whenever she gives this talk, I always like to tag on the strains of HPV associated with cervical cancer are the same ones associated with penile cancer for men, and then anal cancer for both men and women. Anal cancer is not colon cancer. It is a different type of cancer. So we get lots of benefits from having the HPV vaccine. So last but not least, Dr. Taylor is here to talk about breast cancer screening.
Okay, what every woman should know, and so my talk is actually very brief. We have a couple of different things that are going to go on after I talk, so we're going to hit some highlights and try to get back on schedule. First, I have to figure out which button to push. Here we go. Why screening matters. You have heard this over and over today, but it is so true. So early detection saves lives. So these tiny melanomas have a 98% 5-year survival. That's the same with breast cancer. A stage 1 breast cancer has a 98% 5-year survival. So early detection saves lives. Again, just like everything else, most breast cancers don't have any symptoms at all if you catch them early. Breast cancers don't hurt, so painful lumps in your breasts are not typically cancer. So most of the time, no nipple discharge, no pain, early breast cancers have no symptoms. So the whole goal is to find the breast cancer before you ever feel it, right? You want to catch this early so that it's a stage 1 breast cancer and you have a 98% 5-year survival. You don't want to catch it when it's a stage 3 or 4 and your treatment involves much more aggressive therapy. The goal is to detect smaller, more treatable cancers. So current screening recommendations. The first thing is risk assessment by the age of 25. So what does your family history look like? What are other risk factors? And we'll go through that on the next slide. But risk assessment starting at 25, and then mammograms start at 40 unless you're part of a high-risk screening program. So, and the American College of Radiology still recommends annual screening mammograms. So some of the different colleges, family practice, internal medicine, they may say every 2 years, every 3 years. But for screening and prevention, the American College of Surgeons and the American College of Radiology is still annual screening mammograms. And then last are high-risk women, and high-risk women may need earlier screening than starting at the age of 40, and they may need additional screening. And so that's why it's super important to go through your risk factors with your primary care doctor. Okay, so who might need extra screening or earlier screening? So patients with a breast cancer genetic mutation. And so we have very specific guidelines for who needs to have genetic testing. But family history certainly plays into that. Anyone who has had prior chest radiation, so there are some childhood lymphomas and other diseases that patients get chest wall radiation. Those patients need to start their breast cancer screening early because they're at increased risk. This lifetime risk of greater than 20%, any patient with that risk needs to have additional screening. So they get screening every 6 months, an alternating mammogram with a breast MRI is what those current recommendations are. And then we know that dense breast tissue also has an increased chance of developing breast cancer. And I used to think it was that you couldn't see the cancer because in the mammogram everything looked white, but the truth is they actually get more breast cancers. So when we're thinking, this is so hard to read in a super busy slide, but your tyrocusic is your lifetime risk. This is how we're going to calculate whether you fall in the 20% or more and you need to be doing additional screening. So here, and I think now probably most breast imaging centers, when you check in, you fill out a survey, and it asks you questions about when you started menopause, when you started menstruating, what your current age is. It talks about height and weight. So those are personal things for you, your hormone and reproductive history. And then have you ever had to have a biopsy before? Did that biopsy have atypical cells in it, or was it a normal biopsy? Your family history, breast density, which we talked about. And so when you fill this little form out, that's super important to us that it's accurate. We'll take that form and we'll put your breast density in there, and we will calculate what your lifetime risk is. And if your lifetime risk is over 20%, then that's when we start recommending that you have MRIs added to your mammograms. So different breast imaging modalities. A mammogram is what we start with. And then an ultrasound. If you have an abnormal mammogram and we bring you back for an ultrasound, that's a more sensitive way for us to look at that area. And then the last is a breast MRI. And we don't recommend everybody has breast MRIs. They're very sensitive. They lead to a lot of biopsies. This is an example of just a mammogram. I thought maybe it had a pointer on it. So this is the mammogram machine. This is our machine in the back. So we'll take you back and let you look at it. These are some abnormal findings on mammogram. So if you had really dense breasts, this whole breast would be white, and that would make it difficult to find a cancer in it. And that's why those patients need additional imaging. Now, this is a breast MRI. So this is the machine in the back, and you can see, it's not always this obvious, but in some of these, this is probably a benign fibroadenoma, but this is what we're looking at. You can see on the MRI, you can see different enhancements, areas of enhancement, and so the breast radiologist, ours is in the back, can tell the difference between what benign enhancement is and what blood vessel enhancement is. There are myths about should you have a mammogram if you have breast implants. You absolutely should have a mammogram. It's still the first line of screening. It is very, very rare, although we know it can happen, that breast implants get ruptured. We have special paddles that are curved paddles, and we do special views that are implant displaced views, and that pushes the implant out of the way so we can get a good picture of your tissue. MRI is the most sensitive if you're looking for an implant rupture. My talk was short, and I'm getting the wrap-up sign. I do want to say this. So there are very good studies now associating mammograms with coronary artery disease. So these are calcifications in your breast along the blood vessels of your breast, and they look distinctly different than calcifications that would be associated with a cancer. And so we can tell now women who should at least have some sort of conversation with their doctor. So let's see, so breast arterial calcifications are 51% more likely to develop coronary artery disease. What happens after an abnormal mammogram? So we'll be quick. So 10% of people get called back for an abnormal mammogram. So it's a decently high number. when you get called back, you get a breast ultrasound. So typically more advanced views with a mammogram and then an ultrasound. Only 2% of people need a biopsy, and 60% of all biopsies are benign. So 9 out of 10 women who get called back do not have breast cancer. So take a picture of that, remember that. When you get called back for additional imaging, or even if you need to have a biopsy, I don't want you to panic, because remember, we're trying to catch things before they're bad. So we're biopsying things that aren't cancer, and we're supposed to, so that we make sure we don't miss any cancers. Myths about mammograms: radiation from mammograms does not cause breast cancer. Smashing you with a mammogram does not spread your breast cancer. Underwires and deodorant do not cause breast cancer. And just like everybody else, if I feel fine, that doesn't mean you don't need screening. And then thermography, there's a big hype right now. It does not replace a mammogram. It picks up heat sensitivities and things in your body. And I just wanted you to see how vague this is as compared to what this is. So you can add that to your screening regimen if that's something that you feel like is important to you, but the studies show that it's only 25 to 75% specific for breast cancer, whereas a mammogram is up to 90%. So we're not ready for that. Okay, so know your risk, talk about it early, figure out what your screening recommendations are based on your risk factors, and mammograms save lives. So these are our sponsors for today, and Marielle was going to do, Marielle is from Dillard's, and she was going to talk just a little bit about bra fittings and what they have to offer you. Dillard's has really helped. They have put different cosmetic samples and stuff in your bags, and we really appreciate your support.
Thank you so much. I really appreciate your support. Good morning, everybody. My name is Marielle Morgan. I am the business manager for the lingerie department at Dillard's Penn Square here in Oklahoma City. I have been with Dillard's for 14 years. Fitting women is my passion, and I am really excited to share some of the things about it with you this morning. First of all, we do bra fitting like no one else. It's a two-step process. I'm going to call my lovely assistant, Tony, up here to help me here in just a second. But first of all, why get fit? When should you get fit? You should be fit ideally every 6 months to a year. That seems like a lot, maybe, I don't know. But what happens is we gain weight, we lose weight. Maybe you've had a baby. Maybe you're going through menopause. These are all life shifts that show up in the body. And when you have a bra that doesn't fit right, can we all just have that feels miserable, right? When we all have a bra that doesn't fit, you know why. So if your wire is digging, if your wire is pinching, if something's uncomfortable, 9 times out of 10, you're in the wrong size and you need to be fit. So I'm gonna walk you through what we do. We are passionate about helping women find the right fit. So come, oh, I will drop that. Everybody hear me? Here, thank you so much. Yeah, just however. Or I can project. It's all good. So it's a two-step process. There we go. So it's a two-step process. What we end up doing is we're going to measure you around, and then we have a fit bra that we use to help determine cup size and also breast tissue. We have this bra by WalkWhole. This is our retro chic bra. This is what we use on most women to find your fit. 9 times out of 10, this is not going to be the bra you end up in. It is simply the bra. Turn that one off. It is simply the bra that we use to determine your cup size and your breast tissue. But we also have this wonderful bra here by Natori. This is a 28 band, so we go all the way down to a 28 band and all the way up to a 46 band. So we can fit every shape, every body, and it's a very easy process. So what we're gonna do is, if you're in the dressing room with me, I would ask you to take off your top, leave your bra on, and then I'm going to measure around. I always apologize if my hands are cold or if the tape is cold. That's as simple as it is. We just measure around on top of the bust and we pull it a little bit tight, and that's the circumference that we get for around your body. Then, normally I would pull 3 different bras. I would ask Tony what was the last cup size that you were in, that you remember, all that good stuff, and we start with that cup size and then go up or down depending on what's going on. But I know Tony's size, so we're just gonna go with this one. So go ahead, turn around for me. I am coming around. We always go to the first hook. Obviously, this is going to be over the shirt, so it's not exactly what it would be like, but we help determine this. So what we have here, we want to make sure that the center of the bra is tacking flat to the breastbone and separating the breast tissue. If you're smashed and in like this, that's not good, not a good look and not a good feel. So we want to make sure this is tacking flat. As far as the band is concerned, we want to make sure that the band is snug enough around so that if you were to raise your arms, move, anything like that, it's not moving with you, it's staying put. We want it to stay firm and have a good foundation for your body. And then as far as the cup is concerned, the wire here, we want to see that wire, if you'll turn to the side, we want to see that this wire goes all the way back here to the back of her breast tissue. If it's here in this, like digging you here in the center or cutting you off at the half or something like that, it's not encompassing all of that breast tissue. It needs to go all the way back here. That's the reason why your wire is uncomfortable, because it's not actually getting all of that breast tissue. So, like I said, 9 times out of 10, this is not the bra you're going to end up in. We have so many bras, but we also have bras for your lifestyle. We have sports bras, we have sexy bras, we have t-shirt bras, we have all the things. This is about a wardrobe for your life. Bras, I mean, ideally, we wear them every single day, and this is something that's going to wear out on you. It's like a good pair of shoes. It is going to stretch out. So you do want to get fit every 6 months to a year, just to help add to that wardrobe for your body. So I would love to see each and every one of you come to Penn and see us. We have an entire team. There are 6 of us in the lingerie department. We love helping women find the bra that they need, want, and feel good in. We want women to feel empowered in their bodies and empowered in how they dress and how they present themselves. To me, a good bra can really change your life and can change your outlook on life. So come see us. We'd love to see you, and thank you so much to Dr. Taylor.
Well, thank you for doing this for us. Do women need an appointment?
No. I mean, you can if you would like to.
Okay.
You can go online to the Dillard's website, to Penn, and it has a QR code, and you can do that. Or you can just call, or you can just show up. We do it every single day, all day. So, yeah, perfect. Yeah.
All right.
Thank
Thank
you
you.
so much.
Thank you.
Yeah, no, thank you.
Turn this one off.
Okay, are there any questions? We can bring the microphone around if anyone has any specific questions about bra fitting, screening. Dr. Singhal, could you go back there for me?
If you guys ask questions, you get a small prize, so.
So right here, right here.
Why is it after, you don't have to get screenings after 65? I'm 71.
Is that the cervical cancer screening?
Cervical, yeah, the pap smear.
So that can be very individual. I think the assumption is that, you know, if you do have new sexual partners, then yes, screening would still be indicated. But again, the pap smear is just a piece of the pelvic exam. That doesn't mean that you stop seeing your gynecologist at 65 altogether. It just means that you don't need the cervical cancer screening piece at that point.
Yes.
Do you have another?
Kind of on that same line of thought, how often do you recommend the pelvic exam for those that have had like a hysterectomy or a total hysterectomy, since we don't need this cervical part, the pap smear?
So I still recommend that patients come every year. I have a lot of patients that maybe only see me once a year, you know, depending on their primary care and all of that. So it depends. Do you still have ovaries? Do we need to still be screening for that? Breast exam, if somebody else is doing your breast exam. We're still screening for vulvar and vaginal cancers, looking with a pelvic exam. So there's more to it, again, than just the cervical cancer screening piece. So I think some of that could be an individual topic. So if somebody else is doing, covering those other things for you, then you may not need that. But we're also talking about menopause, perimenopause, have you had your colonoscopy? I think as a gynecologist, I start a lot of those conversations. Have you had a skin survey with your dermatologist? So there's a lot of things there. Somebody checking your cholesterol. There's really a lot of more to it than just cervical cancer screening.
Well, and I think the thing that we need to keep in mind, these recommendations for screening is what we would call public health. Public health is where we get a whole bunch of statistics together and say these are the recommendations that we would offer every single woman here in the United States. But that is not having a conversation with your physician, considering your own risks and what your lifestyle is like.
All right. Okay, so my question is, after hysterectomy, what kind of screening do you recommend? Like, HPV and all that? So
again, that depends on your history of HPV screening. If you've had even if you've had a hysterectomy, if you've had, HPV positive tests or dysplasia in the past, you probably still need pap smears. A lot of times I'm the only person doing breast exams for a female in any given year. Making sure that you've had your colonoscopy. So we're still going through all of those things, abdominal exams and, screening, blood work, things like that. So that all just depends on your history.
thanks.
Okay, so for the sake of timeliness, I'm so sorry. I would love for everyone to get their questions answered. You can always come up to us in between sessions and ask these questions. But in order to move on, in order to get to our second session, we're going to stop for just a minute. Each session, what we'll do is we'll do 3 major questions. Whoever is first come, first serve. And then, of course, you can always find us in between. Oh, yes, raffle. First raffle.
QR code that it's right over here so that you can be entered into the raffle.
Have you guys all scanned this to enter the raffle?
Because if you are a latecomer, there's one over there, there's one here. And then Cole, in between each session, Cole chooses a random number. Sarah Yoakum. She's not here, I don't think. Okay. Our first raffle winner. I don't think it worked yesterday. So the first winner is Sarah Yoakum.
Is Sarah Yoakum here? Okay.
Dr. Sarah Yoakum is actually our community independent physician, private physician, and her area of interest is, I'll let you.
Oh, integrative and functional medicine, so mind, body, spirit, wellness oriented.
Yeah. Well, thank you for being here and congratulations. This is titled Building Health Longevity. And I'm so honored to introduce my dear friend, Dr. Julie Wiley. She is an independent private practice owner. She's the one who inspired me to go out on my own as well and delivered my beautiful baby boy, who's 6 now. So she will be talking about a very, very hot topic, perimenopause and responsible hormone replacement therapy. This is the one with a lot of myths and a lot of misinformation out there. So, thank you.
Okay, are we on? Okay, there's a whole world of hormone information and menopause information online now, right? And it's all all over the place. So what is menopause exactly? So menopause is the cessation of periods and decline of estrogen by definition. It's when you've gone 12 full months without a period. Average age of that specifically is 50 to 51. So perimenopause is just kind of the time leading up to that. Menopause and postmenopause are essentially the same thing. So perimenopause is just kind of the pregame, the build up to menopause. It's those years before you actually stop menstruating. And so that can be anywhere from 4 to 7 years. You can start having symptoms of menopause and still have periods, and that can be anywhere from your late 30s to 40s, anywhere in between. Your periods can become irregular during that point. You can have symptoms of perimenopause for 6 months and then not again for a few years. It can come and go. It has to do with estrogen and progesterone that are normally cycling every month, making you have a period, are kind of doing this uncoordinated, chaotic exit. Estrogen and progesterone are the hormones that are made by your ovaries, that are driven by hormones that are made in your brain, that tell your uterus what to do every month if you're not pregnant, right? Okay, so how do you know when you're in menopause or in perimenopause? Again, cessation of periods. Some of the things that you can experience are the irregularity, hot flashes, night sweats, mood changes, irritability is a big one, fatigue, vaginal dryness, which in turn can lead to painful sex, brain fog, forgetfulness, kind of word finding, changes in weight, joint pain, shoulder pain is kind of a notable one, decreased libido. There's a lot of things that can fit into this, and a lot of times perimenopause gets blamed for a lot of things. And a lot of them very well can be related to perimenopause. Itchy ears is kind of a random one that can have to do with menopause. But sometimes I'll have patients that are like, man, I have this shortness of breath or whatever it is. And I'm like, that's probably not perimenopause. We might want to look into some other things. Decreased libido is a big one. So kind of what's happening. This is normally what's happening with our cycles month to month. So this is like 1 month, 1 month, 1 month, 1 month. You have this coordinated increase and decrease of estrogen, progesterone, LH, FSH. What happens in perimenopause is these things are all over the place. So that's why your periods can be random. Now, some people have a regular period every month, just like clockwork, and then they just stop. And that's lovely. But most people don't experience that. Once you get to menopause, everything becomes more steady state. But this is why checking hormone levels, which is always the kind of hot button topic, is your doctor needs to check your hormones. You need to get my hormones checked, you know. It's not always that helpful because you can see, like, if I check it this day and then I check it this day, you're going to get different values that aren't really giving you an answer as to what's going on. Now, sometimes we can check here once you are menopausal, and we're going to know where you are, right? But a lot of the reason that we're checking hormones is because we're ruling out other things. We're ruling out PCOS, we're ruling out thyroid disease, we're ruling out anemia. There's a lot of overlapping symptoms with those things. But essentially what's happening is your estrogen level dips, your FSH goes up. Now this also includes surgical menopause, so meaning you've had your ovaries removed. So estrogen is not just about menopausal symptoms. So I think even 5 or 10 years ago, we were all hesitant to put women on estrogen unless you're having symptoms, meaning you're having hot flashes, night sweats, things like that. But we know that there's lots of other benefits now. This is kind of the plus side of, I think, the social media drive, is that it's increased our drive for knowledge and research in relation to menopause. But we know that estrogen and progesterone are good for other things that we can't see and feel, like our heart, brain, bones, decreased risk of osteoporosis. We also know that it's good for vaginal health and decreasing some vaginal cancers, decreasing UTI risk as far as vaginal estrogen goes. We know that it affects our sleep, our skin, our mood, all of it. So what's the answer? What do we do about it? There's so much information, right? There's probably more misinformation than there is accurate information in regards to hormone replacement therapy. So I think what's important to know is that we have a lot of options that are in the realm of safe, FDA-approved hormone replacement therapy that includes estrogen and progesterone. Progesterone especially important if you do have a uterus. You don't ever want to be on estrogen by itself if that's the case. And then lots of options even within that. So there's transdermal, there's sprays, there's gels, there's patches, there's oral, there's just a ton of different options. It's not one size fits all. Just like with birth control and contraception, what works for one person may not work for another and vice versa. And so, you shouldn't just go to a gynecologist and they offer you one option for hormone replacement therapy. There may be something that you try that works well for most people, but it doesn't work for you, and it's okay to pivot and try something different. And so that's the lovely part, is that we have lots of FDA-approved safe options for hormone replacement therapy. So the key to this, as we talked about with the lab values, the key to it really is treating symptoms. So there's not a benefit to, let me put you on this HRT, let's check your hormone levels again in 3 months and adjust from there. That's not helpful. We know that the HRT that you take or wear does not necessarily correlate with lab values. And so really the key is, are your symptoms controlled? Do we need to adjust from there? Now, there are other non-hormonal options as well. So there are women who can't have hormones for whatever reason. Maybe they have breast cancer, maybe they have a blood clotting risk, whatever it is. We have lots of other options as well, including antidepressants we know can work really well for menopausal symptoms. There are other specific categories that are safe. Vaginal estrogen is safe for everybody. So even if you have a history of blood clots, breast cancer, vaginal estrogen is only absorbed in the vagina. It is not absorbed into your bloodstream, and that can be safe and helpful for really everybody in menopause. We know that lifestyle, exercise, strength training, and protein intake is really important. Adequate sleep is really important. Stress management. And then I like this piece about supplements, because there's 5 million supplements that are being offered for menopause support. And those are not FDA approved. And when things are not FDA approved, you can claim and say and put in whatever you want and say it as truth, right? So you have to be very careful. Now, there are some good things. Calcium and vitamin D we know are good for your bones. We know magnesium can be good for brain health and sleep. Omega-3, good in general, good for your heart. But there's so many things, and I think you have to be careful. And even in the realm of online social media kind of influencers that are offering advice, knowledge about menopause and perimenopause, I like to kind of look deeper and see, like, okay, are you selling something? Like, if I go on your site, do you have an Amazon store where you're selling some supplements, or do you have, your own blend of menopausal tea that is, if you're selling something to me to help with menopause, that's probably not helpful or accurate. You're trying to make money, right, off of my not feeling well. So cautious. Okay, so other things that you can do to kind of help, dressing in layers, of course, because hot flashes can happen anytime. Avoiding alcohol and caffeine, especially before bed. We know regular exercise helps. We know that cognitive behavior therapy can be very helpful, especially with the sleeping piece. Kind of mitigating some mood changes with anxiety, irritability, which is a lot of times, those are the things that those around you notice. You hear people say, like, I have patients all the time, like, my husband says if I don't figure this out, this menopause piece, then this is not gonna go well. So those are, we have help for that. Therapy, of course. Brain fog is a big piece that I think we're learning more about, but prioritizing sleep, I think, is the biggest thing there. Limit multitasking. I mean, I think we're all so good at multitasking, right? And it just gets harder and harder as we get busier and busier with life. Weight gain, the strength training and protein intake is very vital to help mitigate the kind of menopause weight gain. So what's not the answer? This is something I hear a lot every single day and talk about every day. It's a bit of a soapbox for me, but pellets. So pellets are not FDA approved. So you'll hear a lot about pellets for hormone replacement therapy, and they're usually some combination of estrogen, progesterone, testosterone. They are not FDA approved. We don't have any large controlled studies, which is, the gold standard for us to say that medications are safe and effective, to evaluate for pellet therapy. Because of that, because they're not FDA approved, that's why they're so expensive, right? So a lot of times you're paying cash for pellet placement versus, insurance coverage and whatnot. So I think that in and of itself is kind of a red flag. They don't have consistent dosing. Generally, women will get pellets at a hormone clinic or whatever it is, and you feel great for the first few weeks, but then that tapers off, and then when it's due to get them again in another 3 or 4 months, then you feel great again, and then it tapers off. And so a lot of times I'll see patients who are like, hey, I'm doing these pellets, and maybe I feel great, but I have all this acne all of a sudden, and my hair is thinning, and my voice feels deeper, and there's all of these negative side effects. My hair's falling out that can happen in relation to too much of those pellets. And once they're in, you can't take them out. You're kind of stuck with it. And they're expensive. And we have lots of safe, FDA-approved, insurance-covered medications that do just as well, if not better. So this is somebody, if you're kind of looking in the world of social media, influencers, I really like this physician. I think she shares a lot of accurate information in relation to menopause and hormone replacement therapy, but says pellets are unregulated medications. They're not FDA approved. They've never been well studied, and long-term studies that we have, or even short-term studies, we don't know their long-term safety. You should be appropriately counseled on FDA approved hormone therapy. So what social media is getting wrong. Again, I do love that social media has driven this need for knowledge and research in the menopause space, but one thing that you'll hear a lot is bioidentical hormones are safer because they're natural. That is such a misnomer and such a myth. All FDA-approved HRT is bioidentical. That's why they work. That's why all medications that are in the hormone path work the way they do. Take insulin, for instance. You could call it bioidentical insulin if you want, but that's how it works because it's biologically similar to our own. Same with thyroid medication and whatnot. So bioidentical is really, it's a marketing term to get you to use a specific thing. So pellets are the best because they last a long time. They do last a long time, so do side effects, and also they don't have consistent dosing. So just be careful about hormone experts. There's a lot of people that present themselves as a hormone expert because they went to a weekend course about hormones. Lo and behold, sometimes those weekend courses also are getting providers to use their labs, use their supplements, use their, mail-in order hormones. And so that does not make you a hormone expert, right? So I feel like most gynecologists would tell you that we're constantly kind of combating all of this misinformation that exists. So just make sure that you're seeing someone who's trained to manage menopause, not someone who's running a wellness clinic with a sales pitch that went to a weekend course on hormones. So if you're paying cash for labs repeatedly and supplements and hormones outside of insurances, chances are you're funding a business model, not your health. And that's my soapbox. Okay, so menopause is real. You're not imagining it. It affects your brain, body, mood, and more. You don't have to suffer. We have tons of options. We have safe, insurance-covered options, as well as lifestyle support. And then be picky about who you're getting information from. It's not my fault. Okay.
That was incredible. Thank you, Dr. Wiley. So, menopause is coming if you're a woman. We can't prevent it, but what we can do is self-advocate, ask the right questions, and not get fooled. So, thank you for that lovely talk. It's my pleasure to introduce another one of my great friends, Dr. Langens, who's going to talk about a topic that's not discussed enough, wellness and intimacy.
Hi, everyone, and welcome. Okay, so today we have heard so many wonderful things about our bodies and about screenings, and I am here to talk about the mental health and emotional piece. Which button do I press? There we go. I am a licensed marriage and family therapist. I've been practicing since 2008. I am lucky enough to have an office right in this building, right down the hall, and practice with some of these great doctors. I am so passionate about working with people, individuals, and couples. My specialty is sex therapy, and during my second presentation, we'll be talking more about our bodies and about sexual health. Our first thing that we are going to talk about is our core emotions, but before that, I wanted to walk everyone through a breathing exercise to calm myself and to calm everyone else. So this tool you can use at any time when you're feeling overwhelmed, when you're feeling anxious. It is helpful for anyone at any time. So if you want to close your eyes, we can do it together. Inhale through your nose deeply into the bottom of your belly and hold it for a few moments. Then exhale with pursed lips. And your exhale should be as double the length of your inhale. We can do it again. Okay, now that we have some more body awareness, we can talk about our 7 core emotions. Just like the movie Inside Out that I'm sure many of you have seen, those characters of our 7 core emotions are really, really important to know. What do these feelings tell us? They are our survival emotions. They help us determine, are we safe? Are we in danger? What do we want? What brings us pleasure? These are our 7 core emotions: fear, anger, sadness, joy, disgust, excitement, and sexual excitement. We want to bring the most awareness to these 7 core emotions. When we don't listen to our emotions, our inhibitory emotions come up instead, and those are anxiety, guilt, and shame. So if you are feeling anxious, shame, guilt, you're ignoring these 7 core emotions. And this is why therapy helps. Therapy is a safe place, it's a safe room where you can talk individually with someone and realize, why have I been ignoring these 7 core emotions? Unfortunately, starting at a young age, we really learn to tune these out in order for acceptance with our parents, with peer groups, socially. And so we continuously turn off our core emotions, and then these inhibitory emotions come up. Our core emotions are hardwired and automatic. They cannot be overridden by thought. They must be experienced viscerally to be processed, and we must learn to identify and name them. These are inhibitory emotions: anxiety, guilt, and shame. Why do we block the core emotions? They can feel overwhelming to us. We can learn to suppress emotions to fit in. We seek connection and acceptance, and we're taught that some emotions are just not okay. Suppressing emotions creates anxiety, guilt, and shame. Then we go to our defenses, and this is usually kind of where we live. They can be helpful or harmful. They include joking, smiling, laughing, maybe working too much. We do this to protect ourselves, but living in our defenses, living in the inhibitory emotions, is not living a fully authentic life. The cost of living in our defenses is using up all of our emotional energy. You can feel exhausted all the time. They can make you really rigid and inflexible. Maybe you're just like trying to follow life to a T instead of really fully living. We disconnect from our core emotions. And once again, we're just living in those defenses. How therapy can help, we can reconnect with our core emotions, we identify and process these feelings, live more authentically, and make choices from genuine emotions rather than defenses, and we develop a deeper understanding of ourselves. Counseling can help at any age or stage of life. Mental and emotional health deserves attention and care. Living authentically leads to a big, full life instead of a small life. And thank you for being here. My second talk is on sex. So stay tuned. Let me get out my... Okay, let me get out my tools. Okay, I have some props for this one. Okay. So like I said earlier, I specialize in sex and relationship therapy. A couple years ago, I really wanted to understand women's hormones more, and so I went down the path of sex therapy and ended up getting my PhD in clinical sexology in 2024. I love it so much. It's really, really been so interesting, and there's so much to learn, and there's so much education. And my clients are just wonderful to work with, and there's such a great need. Unfortunately, over the last couple years, I've learned that a lot of therapists feel uncomfortable talking about sexuality, and so it's been my pleasure to be able to do that with clients. Let's see. Why does sexuality matter? It is a normal and healthy part of our lives. It shapes how we experience and express ourselves as human beings. Unfortunately, culture, family, trauma, past relationships can negatively affect your sexuality and your connection to your sexuality. Counseling can reduce your anxiety and create a safe space to kind of explore either what's occurred, what were some of those messages as a child or as a teenager, or some of the things that you've experienced, and kind of work through that to get better connected with your own body. Why do people seek sex therapy? It could be sexual pain or dysfunction, something simple like desiring more connected, fulfilling intimacy, could be betrayal, infidelity, something related to pornography use. Desire discrepancy is the most common when one partner would like more sex than the other partner, body image, shame. It could be relationship conflicts, unresolved resentments over years that are getting in the way of your relationship with your partner. Women, I have clients who are married that are virgins that come in and they have so much shame. They haven't had penetration because of fear, because of pain. I have had women in my room that have multiple children but never have had an orgasm. The range is very, very wide and large, but there's so much to explore together in a safe space. It could be a history of sexual abuse. It could be like Dr. Wiley was talking about, perimenopause or menopause sexual pain. And I will go over some products and things that are helpful a little bit later. It could be religious trauma from the purity culture. I've had women in my room just weeping, crying about the messages that they've received. There is like one thing that really stood out to me, that if you've had any sexual experience before marriage, then you are like a used up piece of chewing gum, and no one wants a piece of gum that's already been chewed. Another image that has stayed with me is like if there's a little bit of dirt in your cake, then you can't eat the cake anymore. The whole cake is ruined. So there's just a lot of people that have been influenced, especially at young ages, where your mind, your spirit is just so sensitive and malleable. So the importance of education. A lot of people have inaccurate education about their bodies or about sex. The more we understand about our bodies, the more that we can talk about sex, the better our sex can be. Okay, so let's talk about our vulva and our clitoris. This is my vulva that I have in my room in my office. I bought it on Etsy if anyone's interested in purchasing one. As you can see from this little purple tip, that is our clitoris. That's what you see from the outside of your body or the inside of your body. Every vulva looks very different. The clitoris is different. Every person has a different shape, sensitivity. I need to put this up here so I can open this. Hold on. I think I did it. Okay. So I'm going to open this up so you can see what the clitoris really looks like. It is this whole piece. It looks like a wishbone. The entire thing is about 3.5 to 4.5 inches. When we are aroused, it swells just like a penis. It could swell from 30% to 500%. It has 10,000 nerve endings, and it is the only organ in the male or the female body that is solely for pleasure. So, if you haven't paid attention to yours, you should. It is also an organ that keeps growing throughout our life. So, at 60, our clitoris will be bigger than it was at 20. I know. Very, very interesting. Did I get all the things? Yes. Okay, this book is called Becoming Clitorate, and if you have not heard of it or not read it, it is a phenomenal book. The Audible is great. The book is great. It really provides a lot of education about our bodies, about the messages that we've received over the course of time, and also Chapter 8 you can have your partner read for his or hers education and pleasure as well. Some other helpful products. Earlier, Dr. Wiley was talking about vaginal estrogen. This is an image of the cream. It helps with dryness. Sometimes the skin on your vulva can become thinner and more sensitive. That could cause pain during sex. This is one option. There's also these suppositories. This cream I use, and these I also use. This is called Reverie, and it's a moisturizer. It's a vaginal suppository. You can put it in at night, and it melts, and it lasts like 1 to 3 days, and it just provides moisture. It's a phenomenal product, and there's other ones. This is just one brand. I think they may sell it at Target now. It used to only be sold online, but any vaginal moisturizer, it has hyaluronic acid, almond oil, and also vitamin E. Lube is also our friend. You don't have to feel like you need it. You can just want it. In everyone's bag, I put a couple samples of Uber Lube, which is one of my favorites. And then I put 2 different FDA-approved medications on here. I have not tried them, but I have heard good things about both of them. They're kind of newer on the market. Addie was originally created as an antidepressant, but it didn't work for an antidepressant, and the side effects was increased libido and increased sexual desire. That is a pill that you take every day. Valesi is an injection that works on a different part of the brain, on different neurotransmitters, and that is used 45 minutes before a sexual interaction. But these things I've heard that are helpful and have worked with some clients. Just some important reminders. You are worthy of pleasurable sex. Everyone is worthy of pleasurable sex. Your sexual agency and pleasure belongs to you and is yours to define. Healthy sexuality includes boundaries, consent, and connection. Pleasure and intimacy can look different for every single person. You deserve sex that feels good and is absolutely free of pain. Intimacy and sex can reduce stress and get your mind off your to-do list for a few moments. It can create a more connected relationship with your partner. Healthy sexuality and sexual fulfillment is possible, and you can come into therapy with any sex therapist and work towards your goals, whatever they may be, wherever they fall in that big range. Thank you.
That was fantastic. Thank you, Dr. Langens. I love that line of, "You're worthy of pleasurable sex." I think it's not said enough, especially women in our culture sometimes, a lot of times, are made to feel that something that defines us is our appearances and not being able to have pleasure. So thank you for so beautifully talking about that topic. Next, we have Dr. Anu Bajaj, a renowned plastic surgeon, a dear friend, who wants to talk and who's going to talk to us about not just aging gracefully, but actually aging intentionally.
So apparently, because I'm a plastic surgeon, I know how to age gracefully. And so I wanted to show this slide just because it shows that the aesthetic industry is really growing, and it's grown tremendously post-COVID. And it illustrates our obsession with beauty and anti-aging, because literally on social media, it's everywhere. But one of the things I think is important to realize is, what do we mean by aging gracefully? Because is it either anti-plastic surgery? Is it overdone plastic surgery? It's complex, and I think it's important we delve into what it means. On the one hand, aging gracefully can mean embracing the changes we see with age. And on the other hand, it could be that aging is something that's bad for you, that has to be stopped, which feeds into a fear-based approach. And that's kind of where we've gotten off of track, because I don't think aging is a cosmetic or aesthetic event. It's a systems event. So while we may see wrinkles and weight gain and saggy skin, what we're really also undergoing is muscle loss, bone loss, collagen loss, insulin resistance. It's affecting our entire body. So if we were to think about aging as more than just fighting wrinkles and sagging skin, then our approach should be more involved than just simple cosmetic treatments. And that's where my philosophy is, it's all about daily maintenance. That's why it's you who has control over the aging process. You know, patients expect me to have one treatment or one product that's going to help them age gracefully, but it's not true. 80% of it is what you do every day, and only the other 20% may be related to treatments or products that you can find. Said another way, this is a quote by a very famous plastic surgeon who focused on facelifts, and he says, no matter how fine the tailoring, you still have to deal with the fabric. And so what that means is, ultimately, no matter what magical new treatment is there is only one real truth, and that's that you control it. And so I think of aging more as a pyramid. And at the bottom of the pyramid are all the things that we've been talking about today. They include sleep, nutrition, wellness, taking care of ourselves. And then at the top of the pyramid are aesthetic treatments that you may or may not choose to consider. And you know, that said, when I see my patients, the top 3 things that I see that they are neglecting to do are skincare, strength training, and taking care of their mental well-being. And that truly contributes to the whole aging process that we experience. So, since when we're talking about aging and anti-aging, I'm going to say not everything is created equal. You know, the basic things that have a high ROI are the ones that are the cheapest. Those include the things we've talked about: strength training, sleep, blood pressure control, social connection, even exercise as simple as walking. The lower evidence, higher cost products that we see advertised on social media are expensive, have low ROI, and are unproven. And that includes all the IV therapies, the peptide therapies, all the new expensive gadgets that we get ads for. So I would approach all of those things very cautiously. And so if we look beyond those marketing things, I think the pillars of anti-aging are muscle, building up your muscle, increasing your mobility, and increasing your protein intake, because that is how you're going to age and be able to take care of yourself well into your 80s and 90s. Your metabolic health, your brain health, hormonal replacement, as Dr. Wiley's talked about, and then purpose and community, which goes back to the mental health and sexual connection that we've just heard about as well. One of the most significant transitions that we experience as women is menopause. And so I think I would be remiss if I didn't talk about it. You know, menopause is critical for the aging process. We experience a loss of collagen, and that truly affects how our skin ages. And so what we end up seeing is that our skin appears thinner, it sags, it's drier, we develop acne, we have decreased natural protection from UV rays. But it's not just the hormones that are aging our skin and causing the sagging and the wrinkling. It's also the environmental factors that we heard about earlier. And those are the UV rays. And once again, this is the same truck driver that we saw earlier. And you can see that the UV rays have really damaged his skin and accelerated that aging process of the skin. So some of the other most powerful anti-aging things are in our control and are inexpensive, as I've mentioned. As you can tell, I love to mention strength training. I think staying hydrated and drinking water, I think we need to take our focus away from sodas and flavored or sugared drinks. Good old-fashioned water is what you need. And Dr. Singhal is nodding her head because that's critical also for your colon health. The other thing we need to do is we need to watch our diets better. We need to get rid of all the processed stuff that we eat and eat real food with real color and real variety. And once again, as you can tell, that all the themes are very common because I'm going to say the same thing again, that it's not just about the physical health, but it's about the emotional health. Find your connection. People who age well, stay engaged intellectually, socially, and creatively. So I think when we think about aging intentionally, it's a holistic approach that includes your mental well-being, your hormonal balance, and then I would say your skin as an organ that you need to take care of, and then aesthetic treatments as the bottom or the least important of the whole process. So then you're like, well, why are you here if you're a plastic surgeon? So I would be remiss if I didn't talk a little bit about skin and just briefly about some common aesthetic treatments. I think skincare is the number one neglected thing that we forget about as women that really tells our age. If we take care of our skin, we will age well, and we may decide we never want to pursue aesthetic surgery. If I had to pick the one ingredient that I think that has really stood the test of time for your skin, it's a retinol or vitamin A product. And so retinoids are vitamin A derivatives. They help stimulate cell turnover and stimulate collagen. And they have been proven to improve wrinkles and the skin texture and surface tone. And it's something that I think is critical for everyone to be on to preserve their skin. The other thing that I think is the most important thing as to how your skin ages, as we have seen based on the photographs that I've shared as well as others, is that sunblock is the other most powerful tool. And I am a big proponent of mineral grade sunscreen or sunblocks with titanium or zinc dioxide. They're in good formulations now, they're clear, and I recommend an SPF of 50. And I'm also now getting the 2-minute warning, so I'm gonna rush through it. One question patients, when I talk to them about sunblock, because I talk about skincare with most of my patients who come in for consultations, they all say, well, it's in my makeup. Well, I'm gonna tell you that's not enough. It wears off, and if you're outside doing activities, you have to remember that sunblock will wear off, and you need to reapply it every 90 minutes. And there's some that are available in brush powder form that are easy to brush on your makeup. So I recommend a simple skincare routine. I think you need a cleanser, a toner, a vitamin C product for the morning, a retinol for the evenings, and obviously top it all off with your sunblock. If you are going to invest in aesthetic treatments, I'm going to tell you to spend wisely. Just like Dr. Wiley said, that a lot of things that you pay cash for have no proven scientific record. That's the truth, because when we get medications that we want insurance companies to pay for, they have to go through a testing process to show their efficacy. And so that's where the FDA approval comes in. A lot of the aesthetic crap we're seeing on Instagram, the only person they have to convince to spend money is you. So if they can convince you to part with the money, they don't have to prove that anything works. So be your own advocate and be an educated consumer. And remember that any aesthetic treatment is a tool and not a miracle. And so I'm just going to skip through the little bit on neurotoxins and fillers and all that. And we're going to get to GLP-1, so I'm going to skip some of the stuff. This is the prescription for your aging intentionally. Basically, it's skincare, diet, and exercise as the fundamentals, and aesthetic treatments that are used judiciously, including skin resurfacing once you decide to do it. So, and when you do, if you do consider surgery, be intentional about it. Remember that any type of aesthetic surgery is going to address very concrete things: excess upper eyelid skin, jowls, neck bands, but it's not going to change your skin quality, and it's not going to change the underlying surface that you have, which is your health that we've talked about. So that's going to bring us full circle, and it's not to stop the aging process, it's to age intentionally. And so I hope you think more about looking younger as taking care of yourself and staying healthy, as opposed to buying the next new gadget that's available.
That was fantastic. I always learn something from Dr. Bajaj's talk. I wanted to give her a shout out. Actually, all these paintings, she's also an artist. These are actually done by her. So I love art, and I always admire her paintings. So all these are actually done by her. And I also wanted to give her a shout out because she does have a pretty active social media account. What is it? Bajaj Plastic Surgery. At Bajaj Plastic Surgery, and she's investing her time to actually do a lot of putting good information out on the web. So please do consider following her. So now that brings us to the end of our second panel, and we'll open it for Q&A. If I can ask Dr. Enix to help me. Okay, perfect. Okay. All right. We have a question.
If you have Hashimoto's, which has a lot of the symptoms that you already have in menopause, how do you know when you get to menopause?
I'm guessing this is for Dr. Wiley.
So labs, and really if your thyroid lab values are within normal range and you're still having symptoms, maybe that's when you consider adding in HRT. In theory, you shouldn't be having thyroid-related symptoms if your thyroid labs are in normal range. So that's where we can kind of delineate between the two. And I want to say one thing, too, is that it is Dr. Singhal's birthday. So happy birthday, Dr. Singhal. And she's sharing her birthday with all of us.
All right, I think we need to give a prize. Did you already do that? Okay. Okay, second question. Yes, there it is.
Okay, how do you know when you're transferring from perimenopause to menopause? What are the symptoms?
It's for you.
And what age groups, or what age does it all happen? You know, if you're in your 40s, how do you start to figure out what's what?
Absolutely, such a great question. The question was, how do you know? Because our bodies are always going through changes. How do you know, hey, I need to talk to my doctor about?
So don't always have to know from a treatment standpoint. We can treat your symptoms, right, for perimenopause, which can overflow into menopause, and we are still kind of managing HRT medications based on your symptoms. So we can start that before you hit menopause. There kind of used to be this thought that we didn't treat menopausal symptoms until you were menopausal, until your labs show that you're definitively menopausal, you've gone 12 months without a period, and then that's when we can start treating. And that's just not the case. So you don't always have to know that transition has happened to start treatment. But there may be points along the way that we adjust things accordingly. However, I would add the little tidbit that you can still be ovulating when you're perimenopausal, so contraception is still really, really important. There is. So FSH is kind of an indicator. So let's say you're somebody who had an ablation and you don't have periods, right? Or you don't have a uterus, but you still have ovaries. You may not have the bleeding piece to tell you that you've gone 12 months without a period, but that's where lab values can be helpful. So estrogen levels and your FSH.
I will just add to that. That's such a great question. One, again, highlighting the point that if you're experiencing a symptom, talk to any physician about it, especially your primary care. I have a lot of patients that I am like, hey, I think you may be going through perimenopause, so this fatigue is not normal. If I have done my workup and then I'm referring to OB, our breast surgeons are talking about it or picking that up. Obviously the OB-GYN, obviously I'm sure it comes up with you. As you can see, our bodies it's all connected. So one of the things that I would say is if you're experiencing a symptom, say it. And I say that because it's highly personal to me. I was experiencing fatigue for 3 years, and I was like, oh, I just had a child. I opened my practice. I'm running around. It's normal. 3 years later, there was a point where I came back from procedures, and I just fell asleep, and I was like, okay, it's time to get my iron checked, and my ferritin was like 5. And obviously I'm a doctor. I know these things. I had just ignored my heavy periods after pregnancy for 3 years, thinking it's going to re-equilibrate, and I ended up having an endometrial polyp. So my point is, as women nurturers, we tend to ignore our health. So please speak up, because menopause and perimenopause can have lots of very vague and common symptoms.
And then we also have our next raffle winner, April. April. What did she win, Cole? Cole's like, I don't know.
Is it over there? Let's do the microneedling gift card over there. Doctor, this one? Yeah. Is that one? Yeah. She'll love that.
Dr. Wiley, is HRT to prevent menopausal symptom or to treat it? And the effect of long-term HRT on breast cancer?
So the long-term effect on breast cancer is older research. So hormone replacement therapy is still safe unless you have estrogen, progesterone receptor breast cancer, correct? Okay. So that is not a contraindication. It does not increase your risk of breast cancer, so that's safe. And then the first part of your question is, I think they're kind of one and the same. We wouldn't start HRT to prevent menopausal symptoms, but when somebody is menopausal, or we know that they are having symptoms and they're kind of getting into that, you can start it at any point in that process where you're having symptoms, but we also know that there are those kind of non-symptom-based benefits, right? Like bone health, once you're menopausal and your estrogen levels are decreasing, brain health, heart health. So not that you're going to prevent menopausal symptoms, but there are other benefits as well. So if you have a known breast cancer that is hormone dependent, then that would be a contraindication to HRT. Not necessarily because you have family history or because you're worried about the increased risk, but if you have a known breast cancer.
All right, we're going to wrap up this session, but I encourage anybody who has questions to please find us. We will go ahead with the we will take a 5-minute break.
Everybody, we're going to start our third and final session, and I think our first speaker is going to be the birthday girl, Dr. Singhal, who is going to talk a little bit about a very hot topic in today's world, GLP-1s.
Thank you. All right. Before I start talking about GLP-1s, just a little background, because I think it's very important to make sure you're hearing from a legitimate source. I've been practicing for 11 years. Early in my career, what inspired me to go ahead and get my board certification in obesity medicine was actually you. I had lots and lots of women in my office who I was diagnosing with fatty liver disease. And at that time, all we could tell them was exercise, nutrition, which remained the cornerstones. But I had women crying and saying, I don't want to get liver cirrhosis. There has to be something better. And I just really felt unprepared to answer the questions in the space of obesity. So that inspired me to go get my board certification in obesity medicine in 2020. And I've been practicing gastrometabolic health since then within my space. So today I'll be talking about GLP-1. Just in general, demystifying GLP-1s. So the goal is to address the common topics I hear, common questions patients ask me. How does it work? What are the side effects? How much weight can I expect to lose? Will insurance cover it? How long do I need to stay on it? That's a big one. Can I regain weight after stopping? Is the compounded alternative safe? So let's get right to it. What are GLP-1 drugs really? So we all have a natural hormone, GLP-1. The medications literally mimic the GLP-1 hormone, and eventually all the actions that they're doing in our body is to enhance our normal biological body's response to the food, okay? That's the goal. That's why it works so well. But I explain to my patients something that you need to understand what it does. The whole point of the stomach is to squeeze and churn and help break down food. One of the things GLP-1 does is slows the stomach down, okay? So instead of this squeeze function, it's decreasing that. And by doing that, you have longer periods of satiety, fullness, because the food is taking longer to pass, covering the surface area of the stomach, making you feel satiated, and also sending the signal to our brain that we are full, okay? So there are many ways it works, but that's one of the big ones. And once you understand that, the side effect profile will make sense as well. The other thing that it also does, it stimulates insulin secretion and makes your body more sensitive to the natural occurring hormone, which is insulin, very important for our body. What are the side effects? The common side effects, there are common GI side effects: diarrhea, vomiting, nausea, constipation. There is the Ozempic phase, which rapid weight loss can lead to hollowness and sunkenness of the eyes. There are gallbladder and pancreatic disease risk. Sarcopenia is the muscle loss that we need to be aware of and prevent, and hair loss. So if we know these common side effects, what can I do to help avoid the side effects of GLP-1? You can modify the eating habits. That will definitely help minimize the side effects. Eating slowly and just stopping when we are full. Unfortunately, because of our culture, of oversize me, overfeed me, the restaurants doing supersized meals, we have forgotten what it feels to be full. And these medications really help get us in tune with that feeling. So recognizing that, eating smaller portions, not becoming too active right after eating, because remember that stomach is full, okay? Food choices, low-fat diet, boiled, grilled food over fried, fatty food, key. Water-rich food, incorporating lots of fruits that have hydration already, oranges, raspberries, strawberries. Dr. Bajaj already mentioned that. Avoiding sweets, dressings, soda cans, processed food, the refrigerator diet. By refrigerator diet, I mean the TV meals, okay? Lastly, incorporating light exercises and keeping a food diary. Now, one thing I will say is small, sustainable steps are the key. So I have a lot of people, when I tell them 92 ounces of water daily is really the goal, they have a panic look. Just like some of you are having here. I must admit, I have to be very intentional to reach that goal myself. It's a lot of water. So don't start on day one that my goal is 92 ounces. Let's start, I'm gonna be happy drinking 2 16-ounces water bottles, okay? Small, sustainable goals will lead to success. Don't start running the first day. Okay, today is my day, June 1, I'm gonna make these changes. How about let's just track our steps? 5,000 steps. If you're starting at 5,000 steps, 8,000 steps a day. Slow, sustainable steps, just in general. So, specifically, how do we manage? If you get the side effects, you're doing all the things, what else can we do? Nausea, very, very common. Avoiding strong smells. Taking a little bit of cracker or mint or ginger-based foods about half an hour after your meal can often help blunt that nausea. Vomiting, hydration is the key. If you find yourself, you've had the shot, now you're throwing up, the key is to hydrate your body. And if you're not able to tolerate a lot of water, it's okay to mix some flavor, just small sips to hydrate. Diarrhea, a lot of people do experience diarrhea as well. Hydrating again and avoiding dairy products, yogurt, milk, cheeses for the initial week or two would be very, very helpful. Constipation, high fiber diet and high water intake. And I know you're gonna hear from Dr. Enix, my friend Dr. Enix, and we are so passionate about high fiber diet for our colon health to prevent hemorrhoids. When we talk about fiber, some natural foods that I'd like you to remember, a cup of raspberries, great. A kiwi, the fruit kiwi has been actually studied and is really good for constipation. But the trick is you have to eat with the brown peel, okay? So that is the fibrous portion. So yeah, but it works. I promise you it works. Okay, some other considerations that are important that I think Dr. Bajaj touched on. Rapid weight loss can contribute to hair shedding, so supplementing with proper vitamins, monitoring that. The goal is preserving lean muscle, so the strength training, walking, movement, very important. A balanced long-term nutritional plan is essential. Protein intake, very, very important. So these medications can help, but it is for the long weight loss and healthy journey, it's important to have movement, strength training, and learning how to eat healthy and nutritious food. This is what the Ozempic face can look like before and after. Can GLP-1 cause serious GI problems? Yes, and Dr. Enix is going to talk a lot more about it. Rare, but it can happen. Pancreatitis, gallbladder disease, vomiting. If somebody already has a delayed gastric emptying, meaning their stomach is not squeezing properly, they're diagnosed with gastroparesis, it can definitely worsen that, so we have to be cautious. When do you see a doctor about the side effects? If you're having severe vomiting, cannot keep anything down, severe abdominal pain, inability to pass stool after a couple of days, and jaundice, which is the sign of gallbladder disease, could be a sign of gallbladder disease and pancreatitis. And I will say you should always see a doctor or certified healthcare provider when you're taking GLP-1. No questions asked. This has to be done in a supervised way, okay? Common other quick things about hormones and menopause with GLP-1. We are seeing a lot of anecdotal and patient reporting improvement with GLP-1 around their menopause. There's still evidence that's waiting, randomized controlled trials to be published, but it is something for all of us to note because around menopause, metabolic weight gain and health becomes a big thing. You know, all of us have heard people say, I'm going through menopause, I've put on pounds, I can't lose weight. So there definitely is a role of GLP-1 here. We're still trying to understand it. Okay, quickly, how much weight can I expect to lose? These are the common GLP-1s. Semaglutide, which is a GLP-1, that's your ingredient in Ozempic, it's 12% weight loss, total body weight loss. Now we have Mounjaro or tirzepatide, and that is a dual agonist medication, and it has shown in very, very legitimate studies, very large population studies, weight loss up to 20%. But this doesn't happen overnight. This happens slowly in a healthy way over months. Do I need to stay on them forever? The data suggests yes, you have to be in a supervised way. We don't know, basically the concept of microdosing is real. So we get to the ideal weight after maximizing the dose, and then slowly decrease the dose and get you to maintenance. In a lot of patients, I've successfully been able to get them off of it if they've been very compliant and incorporated the lifestyle stuff that we just talked about. So I'm getting the sign of wrapping up. So, but I do want to hit just one last point, is the insurance coverage. There's a lot of issues with accessibility, and that's because the insurance do not cover it. You have typical cash pay without insurance is $1,300 to $1,400 a month on all these medications. But here's the good news. The big companies for Wegovy and Zepbound is Lilly and NovoCare for Wegovy, now are trying to compete with the compounded pharmacies, and they have options of $200 to $350 a month, and Lilly Direct has $300 to $450 a month. And I just got, within last week, notification that for Medicare, these medications are going to be approved in fall fully. So the indication they're covered for very well is diabetes. Obesity is not, so we are still fighting. But Medicare, because they're compounding other things, usually like cardiometabolic health, we are seeing more and more coverage. And lastly, what exactly is compounding pharmacy? Compounding pharmacies exist because there's demand for medications that are not being covered by insurances, and we know it works. So it's pharmacies that are taking the ingredient, but these making the similar compound and selling them for cheap, but they're not regulated by FDA. FDA is Food and Drug Administration, and it's very important for these kind of medications, for any medication really, you have heard us all talk about it, that they're FDA. Lack of FDA approval means there's no regulation on quality and purity. There's no dose control. I just reviewed a case for a lawyer that there was a concern of double the dose in a compounding pharmacy. The point is, you have to be careful of what you're putting in your body, okay? And lastly, my takeaway here is, Obesity is a chronic disease. By 2030, 1 out of 2 Americans is going to be obese. It's not going anywhere, so we have to prevent it. We have to address it. GLP-1 medications absolutely work when taken properly and under the care of somebody who is licensed and educated to do so. They do have contraindications and can have serious side effects, so it's even more important to know about those, like I mentioned. And I know Dr. Enix is going to be talking about some of the other side effects, so thank you.
And I would just like to add in the information about the GLP-1s, their access. So we have seen this increase in the use of compounding pharmacies. Compounding pharmacies will still be better than purchasing a peptide powder on the research market. That is not safe. Compounding it yourself at home, you are not a licensed pharmacy. A compounding pharmacy, we need to pick a good one. We need to pick one that we trust. But they are monitored by licensing boards that can penalize them. So in this case, unfortunately, there is recourse for a patient that was harmed by a medication that was produced by a licensed pharmacy. If you purchase it off the internet, compound it yourself, good luck. So, as I mentioned before, I'm a board-certified general surgeon. Our realm is mostly the abdomen, so we'll be kind of talking about things starting here all the way down. So I always love to talk about the complexity of the GI tract. I get a lot of referrals for plain old abdominal pain, and it can be really difficult to figure out. We need to respect how incredibly important, complex, and what our GI system does for us every day. We'll talk about medical options to try to prevent any sort of surgical intervention, and of course surgery, because this is what I do. So this is what happens whenever we take something into our body. We put it into our mouth, we chew it up, we swallow it down, our muscles reflex, we force them to do that up here, and then the body takes over down here. Dr. Singhal already talked about the churning of the stomach, how it turns over, dumps into our small intestines, and then it takes forever to move through the small intestines to the colon. Once the moisture is absorbed, we eventually evacuate it. Something I always tell my patients is, please respect your body. Understand that it's only second in complexity to your nervous system. It responds to the same hormones, the same stressors, what is going on in your body. But in addition to that, we ask it to take in what is healthy for us from our external environment and get rid of what is unhealthy for us. So we're taxing it every single day. And we want to feed it good stuff. So, fiber. Every single person that knows me, any of my friends, all know that I recommend fiber supplements. The ones that mimic fruits and vegetables the most are a combination of soluble and insoluble fiber. The ones that you hear about the most being Metamucil and Benefiber. Interestingly enough, we can manipulate the types of fiber if you take it as a supplement to try to improve some of your GI symptoms without necessarily having to put you on a prescription medication. Next, the magnesium supplement. This is so helpful. Dr. Wiley mentioned it. It can help with sleep, help with a sense of calmness, and it also promotes GI regularity. We take it in supplement doses, not mega doses, because Dr. Singhal and I can actually use it as a prep when preparing for things like colonoscopy and colon surgeries. And then lastly is a probiotic. I do all of these things personally. The probiotic recommendation, if you are truly having some sort of GI symptoms, it seems like the studies show us that the inflection point is at 50 billion colony-forming units of bacteria in your probiotic. But we honestly don't have great studies about this. I take mine in pill form because it's most consistent. There are great options with yogurts, kombucha, but don't take it with the added sugar. Probiotic in the edible form is earthy and kind of acidic tasting. So we were just talking about the GLP-1, right? So this has actually drastically changed my practice in the way I counsel patients, especially in the most common symptom that a surgeon sees, which is cholelithiasis, gallstones. So we talked about how it slows things down. We see a lot of reflux problems, some nausea and vomiting. So the first thing I wanted to start with, because this is a really big deal, and it has really changed how I have counseled some of the patients that I've seen. There is a condition called a hiatal hernia. I did not talk about this previously because it's not all that common, but it's a portion of the stomach that slips up into the chest and it predisposes you to reflux. We try everything we can to fix the symptoms without moving forward with surgical intervention. But if we can't get those symptoms controlled, we proceed with surgery. Now, with the introduction of the GLP-1s, we are seeing a significant amount more of reflux when we see a patient that has a hiatal hernia. This becomes a difficult conversation. As a surgeon, I have a tendency, this is the very few areas that I have a tendency to recommend actually stopping the GLP-1. Hiatal hernia surgery is a pretty significant surgery where I'm moving your stomach from your chest back down into your abdomen. And if you've got another 20 years of your life to go, it's probably going to come back over time. So this is one of those little tiny areas that has seen a huge change in how we counsel patients just because of this one revolutionary medication. So this one. This is the thing that I really, really commonly see now. Gallstone surgery, removing someone's gallbladder, is actually the most common general surgery done in the United States. So I saw this a lot to begin with. But the thing that is different now is when I'm seeing a patient with symptoms and we know it's from gallstone disease, I say, have you started a GLP-1? And when you started it, this is where I thought about removing this because I talk about it multiple times a year, but I just find it so helpful because hemorrhoids and perianal health is something that almost all of us women experience throughout our lives. So I always like to keep this in the presentation. So we're a little bit different than men in that our pelvic anatomy, we have a much more complex pelvic floor, and then of course many of us go through pregnancy, which is the #1 cause of hemorrhoid disease and perianal issues in women. This shows us all these muscles, how they're communicating, and I will actually have to change the way I'm counseling because I used to counsel patients that the perianal tissue is the most highly innervated part of the body. In women, it apparently is the second most highly innervated part of the body. In men, it remains the most highly innervated part of the body. So hemorrhoids are things that we're actually naturally born with. It is a vascular column that helps reinforce your sphincter muscle. It allows us to hold pressure. That way we can pass gas without passing stool. If we need to have a bowel movement and we're not in a socially acceptable place to do that, we can hold lots and lots of pressure. So we have these natural vascular columns, which means that over time, if we stress them out, add extra pressure to the area, they can start to dilate. The other thing I like to touch on is an anal fissure, mostly to make sure that you have the information because I love our primary care doctors. They take care of so many things, but this is also something that is commonly missed by primary care. You go in with complaints of anal pain with a bowel movement, they're going to send you for hemorrhoids much of the time. So we want to talk about all these healthy habits. I have so many conversations about sitting on the toilet, sitting appropriately, the use of bidets, wet wipes, a squatty potty. Game changer, changes the angle of how the stool comes out of your bottom. So if you're having any problems at all with hemorrhoids or painful bowel movements, making these simple changes without any sort of surgical intervention makes a difference. This gives you the anatomy change of what a squatty potty does for you. So anything that can hurt your back can worsen your hemorrhoids. We always want to do safe, effective lifting. And then pelvic floor physical therapy can be so helpful, especially if we have a history of pregnancy, vaginal delivery, and multiple vaginal deliveries. So medical treatments, we talk about fiber supplement, minimal time on the toilet seat. It is only for business. I would love to get a bidet in every single American home here. It won't happen, but the next best option is bidets, is Tux pads, wet wipes, something with witch hazel in them. If you are having a flare, you could just simply sit in a warm bath. It helps, makes some of the swelling go down, but it's mostly for discomfort. We talked about pelvic floor PT. Unfortunately, our pelvic floor physical therapist was unavailable this year, but they can really help with reconnecting with that part of our body and help us have effective, safe, and appropriate bowel movements. And then, of course, the topical creams. Now, I mention this because if you are prescribed a hemorrhoid cream and you have an anal fissure, this is a big no-no. Anal fissures feel like razor blades when you're having a bowel movement. Hemorrhoids burn, they itch, they feel awful. But if you have a bowel movement and you feel like a razor blade is coming out of your bottom, you do not put hemorrhoid cream on that. And I always like to talk about this, why? So if I have a patient that comes in, oftentimes we'll see these two things together. They'll have an anal fissure and hemorrhoids. And they've been given steroid treatments. So a hemorrhoid cream has a vasoconstrictor, tightens down that dilated vessel. And then they also have steroids, which decreases inflammation. Well, what do those medications do? It actually decreases the body's ability to heal something. What an anal fissure is it is a split. It is a paper cut right over the sphincter muscle where the stool comes out. Now, if we can't get it fixed, my surgical option for treatment is to actually cut the anal sphincter muscle in half. So it's a circle, and I cut it, and it opens. There is no surgeon in the world that can tell you they can do that surgery without a risk of stool incontinence. It is low, but it is not zero. So that is why this is always so different, and I stress it every single time I talk about perianal health. Okay, we don't have to see the scalpel, what it actually looks like. So, hemorrhoid surgery. So if we've exhausted all of these things for internal and external hemorrhoids, there are a couple options for actual interventions, and I offer all of these. Rubber band ligation. This is something that can be done on a Friday, and by Monday you're feeling really well, but it only treats what is on the inside, and it does not treat anything on the outside. The next option is internal hemorrhoid removal. So that's where I actually remove the hemorrhoids themselves and sew them up, but again, does not remove the stuff on the outside. And then this is what gives us the best results. But we talked about how highly innervated the bottom is. And this is a very painful surgery. So this is why we try to prevent and try to treat and try to do everything we can without some sort of surgical intervention. I wanted to touch on anal condyloma just real quick, and we'll finish up. This is a new area of treatment, and I actually take care of it. Right now, I'm seeing mostly what we would consider higher risk patients, so those with HIV and AIDS or those considered immunocompromised. We know that if they have an HPV strain associated with cervix dysplasia, or we have men that have a known history of having anal condyloma, they are at higher risk for anal cancer. So the Gardasil vaccine makes a huge difference. I am working to try to get some patients approved over 45 to get the vaccine. That's been somewhat difficult, but we have cash pay options to help decrease that risk. And then screening. This is something that I'm really trying to stay on top of. We don't have any recommendations for it, but this type of screening we know is very important. So Farrah Fawcett, if everyone remembers her, she actually died of anal cancer, and it was related to an HPV strain. So we know that something is going on there. We just have to figure out how best to follow this and take care of it. And that is it. So this, if you do have any questions, we'll have one more speaker, and then we'll be wrapping up.
Good afternoon. I am very aware that I stand in the way of what I have to say in your Saturday, so this is going to be brief. You have gotten a lot of information this morning and about medication and screenings and gut health and what you can do. I'm going to zoom out and go about 30,000 feet and kind of talk about some basics. And I've sort of structured this the way that I counsel my patients about prevention. So screening finds disease, and prevention is actually what keeps it from happening in the first place, and wellness is what you feel when your body's telling you things are okay. So I counsel my patients around 5 levers, and I'm going to echo what several of my colleagues this morning have said. But I think I'm going to try to be a little more prescriptive about it, because lifestyle and stress are terms that as clinicians we hear about, read about, understand, but we don't necessarily dissect out for our patients. And oftentimes just some education around numbers and what you can do in your lifestyle and the way you're living can be remarkably helpful and empowering for you. So most women know their weight, but they don't know their insulin, their fasting insulin. And that's really important, because your metabolic health is not your weight. It's not a number on a scale. It's actually whether you're crashing at 2 p.m. in the afternoon and running on caffeine, because that is probably the first indicator that you don't have the metabolic resilience that you had when you didn't need to do that. Those normal dips are often an indicator of early metabolic changes, and in the longevity medicine world, we're not really looking at weight, we're looking at visceral fat, and we're looking at insulin resistance, because you can look healthy and still be having metabolic changes that are impacting your heart, but most importantly, and what's becoming even more critical and talked about, is your cognitive health and the cognitive decline that we're seeing as people live longer. 50 or 60 years ago, our lifespan was around between 50 and 60, 52 to be exact, prior to immunizations. But after immunizations, we're living well into our 70s. And what was called chronic illness and the idea of a new diagnosis developing and what we term aging really is metabolic change over time. And so you can impact it. If your energy is unstable, your metabolism is unstable. So the second thing that several of my colleagues have spoken about is muscle. And this is the most underappreciated area within women's health. Women are told to lose weight and to be within a particular BMI, but muscle is not cosmetic, it's actually metabolic. It's what controls your blood sugar, it's what controls your bones, and it's actually what controls how you age. Muscle is not about strength, it's about independence and how long you're going to hold on to it for as long as you live. In the longevity space, and in my practice in particular, we actually track grip strength as a vital sign, particularly for our patients who are on GLP-1s, because that is actually a tangible metric that we can watch as we help patients lose weight and become more metabolically resilient. Strength is protective. I really want to emphasize this. Sleep is not rest. Sleep is regulation. So when sleep is off, your cortisol goes up, your insulin goes up, and your hunger hormones go up, which means you have more cravings, you have more fatigue, you have more weight gain. We try to fix that with diet, we try to fix it with medication, but the root issue is sleep. You cannot out-diet and you cannot out-exercise poor sleep. You just can't. And in medicine, we do a lot of prescribing, but sleep is arguably one of the most powerful tools we have for recovery and for maintaining health. And a question we often get asked is, how much sleep do I need? You need 7 to 9 hours of sleep no matter who you are. I mean, whether you're a doctor, whether you're a nurse, whether you're an architect, no matter who you are, that is what you need. So as women, we are generally looked upon to work, to take care of our children, to do a lot of managing of our relationships. We talk about social connection and the importance of it. Arguably, 75% of more of that comes down on women. Women do that. Aging parents, everyone relies on us. But stress is not occasional, it's chronic. And the more activated and turned on your nervous system is, the more your metabolism is working. Your hormones are working and you're not sleeping as well. So everything that we've talked about today is not about eliminating stress, because we're not going to do that, but it's about being realistic around creating moments where your body can actually rest. And if your body never feels safe, you never function optimally. And part of that is the mental health and well-being that we've spoken about. But it's also being clued into the fact that there is treatment available for anxiety, for sleep, that will help you age better if you attend to it. The stigma around intervention that we've developed in modern times, there's reality to it, but there's also bias against seeking treatment. And as a primary care doctor, I would say the last piece of this that is under, I think, discussed is having someone that works with you so you're not in isolation, who understands that prevention is not a lab, prevention is not it's not a test, it's not a treatment. Prevention is patterns that get recognized over time, and having someone that works with you that's monitoring to see what baselines were and how things are changing in your life. The other thing that matters a lot is your story, and it matters, the life you live matters. It informs the decisions you make, it informs the relationships and the quality that you have, and it informs how you age. And so having a doctor who is actually a partner in your health is really important. We don't have a health system that's designed to enable that for you. And so I'm just going to push back a little bit on the cash-based piece of it, because there's a movement now with what I do in primary care to allow you to have physicians that spend an hour with you every single visit and really are your primary care doctor. And I would say the real doctor in your life that can help you manage, coordinate, and move through the complexity of all the information you have access to now, but also all of the opportunity and hope we have with all that we're learning. Thank you.
All right, any questions?
Are you seeing any greater correlations between GLP-1s and thyroid?
So what I would say is that the studies, the long-term studies, and specifically the sort of gold study around GLP-1s, did not show adverse effects in humans. It showed the risk in rats of T-cell carcinoma of the thyroid. But I would say in my practice, responsible screening and lab work for GLP-1s absolutely includes comprehensive thyroid monitoring. I have seen in just a very small number of patients changes into hyperthyroidism, and I stop the drug when I see that. But I'd be very interested to hear what my colleagues who are routinely prescribing these are also seeing.
Yeah, absolutely. Great question. So one of the contraindications for GLP-1 is medullary thyroid carcinoma, and that's based on the study that Dr. Jaffrey was referring to. So the contraindication is if you already have history of thyroid cancer to be cautious, and that's a contraindication. But if you've had medullary thyroid cancer, then it's a complete contraindication. And one of the other things we want to make sure is you don't have MEN2 syndrome, which is multiple members in your family having thyroid conditions and specific criteria that meets it. Having said that, I think your question specifically is asking, with the weight loss, are we seeing fluctuation in thyroid hormone? Is that correct? I want to make sure we're being as specific as you want.
I'm looking at fluctuation of thyroid hormones, but also thyroid nodules. Because some of the hospitals that I've talked to, the radiologists doing ultrasounds have seen increases
Yeah.
in the episodes of thyroid nodules.
So,
People that have no thyroid history.
So that's, again, a great point. So a lot of that is happening. So there's no study relating GLP-1 direct correlation with thyroid nodules, but are we seeing that in real life? Yes, but one of the hypotheses for that is because there's so much weight loss around the neck that the thyroid screenings are much better. People are able to feel their neck, and all of a sudden it becomes prominent that they may have nodules. So that, I mean, personally myself, I've had two patients like, hey, I never felt this before, and we, kind of visited and talked more about it, and they both had significant weight loss. Unfortunately, their obviously appropriate referral and workup was negative. It was incidental thyroid nodules that were benign. So it did not need any further treatment, or there was no panic for it. But there is no study that is yet evidence-based that there are increased thyroid nodules. But we are seeing that, which, like I said, one hypothesis is that. We have an endocrinologist in the back. Dr. Shah, you have a comment?
Great talks, Dr. Singhal and everyone. I'm Kruti Shah. I'm a pediatric endocrinologist. So I completely echo with, the contraindication on medullary thyroid carcinoma. That's an absolute contraindication. Now, I would have a question to Dr. Singhal. We recently had a patient this week, a child on GLP-1 with pancreatitis. So what are your thoughts on, she was on Ozempic, and when she was on a higher dose, she got pancreatitis. So I know you mentioned, that's one of the side effects.
Yeah, so it is definitely a known side effect. It's rare, but it's reported in approximately 1 to 2% with higher doses. There are a couple of mechanisms with that. One, we know for a fact that when you have rapid weight loss, when I'm talking about rapid weight loss, I'm talking about more than 50 pounds over 6 months. Our bodies are not used to it, obviously, because we've held on to that weight for a long time. And this is true in bariatric surgery as well. When you have gastric sleeves or lap bands, we have seen this. When you have that weight loss, you precipitate gallbladder disease. You precipitate gallbladder stones. The gallbladder stops functioning well. So one of the mechanisms of pancreatitis is gallstone pancreatitis. So the gallstones, the little stones in the gallbladder dislodge and obstruct the pancreatic duct, causing pancreatitis. So that's one mechanism. I'm not sure in that particular patient, but there is a low incidence of direct just GLP-1 and pancreatitis. Unfortunately, there's no way for us to screen for that or prevent it besides just educating. One of my indications of really talking to your physician about side effects is if you're having severe abdominal pain or abdominal pain that's more than just gas. So thank you for highlighting that, but that exists.
And I would just go back to that thyroid question just real quick. Interestingly enough, as a general surgeon, I do thyroidectomies as well. And this is just this new horizon of GLP-1s. This is likely anecdotal information that radiologists are seeing, right? So an increased amount as the patients get thinner, they're having more symptoms and they can come in. Prior to GLP-1s being on the market, the most common cause for a referral for a thyroid nodule was an incidental finding for another imaging study. So you go in for a CT scan or you go in for something else and this nodule was found. So this is an area that we'll have to watch closely. Thyroid gland is involved in every aspect of the way your body works. Do we have one more question and then we'll...
Yes. What about GLP-1 post-bariatric surgery? How does that work?
Excellent question. So there's definitely a role of GLP-1 post-bariatric surgery, whether it's gastric sleeve. In fact, in GI world, the endoscopic sleeve gastroplasty, which is the newest procedure known as ESG, has results that are parallel to, if not better, than bariatric surgery. So again, obesity is a chronic disease and weight loss is truly a journey. So even we have seen patients with post-gastric bypass who have regained weight. So now there's very, very good data and very good studies highlighting the role of GLP-1 for maintenance of the weight and not having to regain and relapse. So there's absolutely a role. Lots of bariatric surgeons have embraced it, but there's very good documentation of evidence that for maintenance, you should consider GLP-1.